Okay, guys, so I am super excited to have with us all the way from Canada, Dr. Kim Blake, who's a professor of pediatrics at Dalhousie University in Nova Scotia, Canada. She has been researching CHARD syndrome over the last 35 years. She's extensively published, has developed a zebrafish model of CHARD syndrome, and so much more. I really recommend you all go on her website. It's www.drkimblake.com. Again, doctor as in DR, kimblake.com. Amazing stuff. Do it. You will not regret it. Good morning.
Thank you, Yarden. Thank you very much for that lovely introduction.
So
Where would you like me to start?
Yeah, I think we're going to just dive into it. I would love if you could tell our listeners a little bit about yourself and why you decided to start researching CHARD syndrome.
Thank you. So I'm in Canada, but as you can hear, I'm very English, British. I was born in London. I grew up with no family members that went to university. So I was the first doctor and first university member of my family, which was wonderful for them and for me. I was very proud. So after my training, I became a pediatrician, and then I was working at Great Ormond Street, which is a very prestigious hospital in London for sick kids. It's called GOS for short. And I was on the cardiac ward, and I was an SHO, senior house officer, about 26 years old. And I met my first little boy with CHARD syndrome. He's called Nicholas. Nicholas was amazing. He had a trach. He was 18 months. He was like, his non-verbal communication was brilliant. I went to the literature, and all the literature said that these kids were severely developmentally delayed. At that time, mentally retarded was the terminology. They couldn't do this, they couldn't do that. Their life expectancy was not great. And I thought, well, this is a very different picture. And the mum and the dad said to me, one of the things they were so worried about is all these doctors came from everywhere and they never knew who was who. And as you all know, we all change over every 3 months or 6 months or whatever it is. And it was funny because I was with them for a very short time, only 3 months, but they got to know me and I got to know them. And I did grand rounds on who's in charge. Who's in charge of CHARD patients, because they're so complex inside and out. And I spoke in front of my peers and the consultants, and one of the consultants said, "You're not going to be researching in CHARD syndrome, are you?" I said, "Well, why not? It's very interesting, very, very, makes you think." And he said, "You will never make your name in CHARD syndrome." So here I am.
Yeah, you showed him.
I showed him. Thank you.
Okay, so if you don't mind, just because most of our listeners are second-year med students, and they have never seen, just like me, have never seen a CHARD syndrome patient, would you mind explaining a little bit about the symptoms and characteristics of CHARD syndrome? Just something brief so everyone's on the same page.
Absolutely. So as Yarden and I were discussing before, it's more common than one realizes. About 1 in 10,000. We did an incidence and prevalence study here in Canada, and we found it was probably more like 1 in 8,500. So it's there, but there's such a spectrum of the phenotype. So the phenotype being how it presents. So CHARD syndrome is originally was given the mnemonic back in the 1980s, early 1980s, which is CHARGE. So everybody remembers it from that. And given my degree of own dyslexia, I always have to write it down because I always forget. I think of it, though, as a cranial nerve anomaly syndrome. So I know that you all learn your cranial nerves in Med 2, and I love teaching med students. And on my website, there's a lot of teaching stuff as well I've put on there. So it's also good to go there for other things. So given that, it's cranial nerve and the 4 C's is what we promoted CHARD as, because there are very few syndromes where there are cranial nerves involved. And that, especially the facial palsy, sensory neural hearing loss, problem with the eyes, problem with swallowing, problem with taste, smell. You can think of it, as you work down your cranial nerves, you can actually, and I'm now very interested in the vagus nerve, the wandering nerve. So we'll come to that later. But, you know, at the basic level, people always remember it as CHARGE. So essentially you've got coloboma of the eye, abnormalities in the iris, a little keyhole, or at the back of the retina. The retina is more common. So again, you can realize how some of these abnormalities are hidden inside. And when I teach about a syndrome, I always say, everybody's got an inside and an outside. So the outside is easy to see the bits, but you always think of the inside. So the inside of the eye can be affected. The ears, see, I've even forgotten what CHARGE stands for now. Isn't that terrible? And I've got, okay, you can remind me what CHARGE stands for. So I've got it, coloboma here. So I never think of it. I think of it as the 4 C's. So heart abnormalities are midline. So the midline heart abnormalities can be something simple like a PDA or a aortic vascular ring, or it can be something more like tetralogy of Fallot. Then you've got atresia of the choanal, so that's the nose. It can be completely closed off on both sides. That's bilateral posterior choanal atresia, which means that when you're born, you need emergency help because you can't breathe. So a lot of babies get picked up at birth with a heart defect, or because they're not able to get oxygen through and breathing, so they need ventilation. So that's when the more severe ones get picked up. But the minor ones, so say you have a choanal stenosis on one side and a small amount of retinal coloboma, you can see how they can get missed and not picked up. And I bet you, in your wonderful country of Israel, which I've visited many times, there are many people with CHARGE syndrome that aren't getting recognized. Then you've got retardation of growth and development. We'll come to development a bit later, but as growth is one of the things that we see, and we see that in a lot of babies with congenital syndromes. So that's quite common with lots of syndromes. But the ear abnormalities are interesting. They're sort of cup-shaped ears. So this bit becomes cupped, the pinna at the top, and locked, and that classical ear abnormality is another visual feature with the facial palsy, because that's one of the cranial nerves. But you can see in the CHARGE, there isn't the cranial nerve sort of push to it. So really, if you're seeing anybody with a coloboma, or so I think sensory neural hearing loss and especially coloboma or eye abnormalities, think CHARGE syndrome, and especially if they've got facial palsy as well.
Thank you for that. I think that was very on top of what I've read, which, to be honest, it was pretty difficult. I told you before, it was pretty difficult to find a lot of information and to find here in Israel patients and doctors that worked with CHARGE. Eventually we found some. I mean, we'll hear them in the podcast, but before that, we needed to go all the way to Canada for you. If you don't mind, just because this is part of a genetics course, could you please explain to us in a few words about the genetic component of CHARGE syndrome?
Yes, so it's an autosomal dominant gene. That does mean that it's probably mostly, and well, we know it's a nouveau deletion. So essentially, most parents don't carry it. The genes happened de novo. So it's on chromosome 8. It's CHD7 gene. It's a huge gene, so it can be. There's lots of parts of the gene that don't code for anything. But within that gene, that's how abnormalities of the gene, and one gets the phenotype and the genotype of CHARGE syndrome. It's passed on autosomally dominantly, so 50% of affected individuals will have fetuses that will carry that gene, and they may go to term or not. It was discovered about actually nearly 20 years ago. So the research now has increased because we know about the gene abnormality. Because it's a huge gene and a huge phenotype, there is still lots of work being done on the sort of correlation of things. And of course, with all the new methods of treatment, whether anything can be done about that. There are families and siblings and twins, and there are people, but it's rare. But we still do tests because of the carriage rate. But some of my patients with the more mild characteristics, it's very interesting that they will be missed in a population. So I very much go for I mean, it's a clinical diagnosis, and I know we're coming to that question much before it's a genetic diagnosis. We have to diagnose it clinically and then ask the geneticists to essentially do their work.
Okay, so if I understood correctly, first of all, you see a child, you diagnose them clinically, and only then will you look in their like genetic background. So it's not something that you search for while like during a pregnancy, right?
No, it isn't. It isn't. It can be if you've got some of the now with our wonderful ultrasound techniques and things like that. If you're suspect of that, it could be looked for. I don't think that's anything that's being done, but certainly if somebody's had one pregnancy that's resulted in an individual with Charge syndrome, then maybe it's certainly very important to test the parents and then follow up with the next pregnancy. I'm not a geneticist, I will say that. I'm a general pediatrician, so I always veer on the side of staying away from the genetics. But my basic feeling as a clinician is you've got to pick this up clinically, and you've got to be aware of the diagnosis clinically. And some of the more milder individuals that I've picked up have been just sort of walking past them in a corridor. That was one person. So I think you have to have people that are interested in Charge and interested in and I think that increases your availability to diagnose. And that's why we've got a higher prevalence in Nova Scotia, in our part of Canada, is higher than anywhere else, because we're much more aware of it. So we're finding individuals with Charge syndrome where other people won't find them. So being a medical students can diagnose. So hopefully somebody listening there will say, I saw a little girl or boy and had facial palsy, and I wonder if there's something else going on there. So yeah, this is good education.
That's for sure. I completely agree with you. I think that like a lot of other things, like HD that nobody really was looking for, and now that you're looking for it, you find a lot more people. So I feel like that was the same thing with us searching for Charge patients and people who like are in the field. And when you start searching, you find, guys. So
absolutely, when you start looking, you find.
Yeah. So about the diagnosis, if you could just give me an overview of what would happen if somebody walks into your clinic and you think he has, like, what are the things that you do to diagnose Charge syndrome?
That's a good question. So I think there's two ways. One is there's the diagnosis, as I said, on the neonatal unit, where you've got somebody coming in distress, needs ventilating. They do the scans. They find out that there's a obstruction to the airway, like the choanal atresia, which is bilateral, or a heart defect. And then you get a big workup for the child. So that usually happens there and then. So that's in some ways, it's the easy ones, because then you sort of have everybody involved and the whole teams come down and start working with the child. But what's really interesting is they're all individual people often. You need somebody to pull things together. I'm very lucky. I work with a nurse practitioner who has worked with complex care children, and we pull everything together. So one of the things I use is the checklist, which is on my website, and it's called the Charge Syndrome Checklist, which we designed very much like a checklist you might have seen for Down syndrome or something like that, but very comprehensive. You have to put a lot on one page. We spent a long while getting things on one. There's one thing missing now, because there's another thing that I've been researching in that needs to go on that checklist. But the checklist is always something in motion. But if you look at that checklist, and I hope some of you will go to the website, I'm very proud of that, probably as the best bit of research, one of the best bits of I think, practical research that's been done. So charge patient in clinic. I've got a little patient coming from Syria, actually, who's just, we're having a lot of refugees, and they're coming to my next charge clinic, and they're 2 years old with charge syndrome, and they're bringing their records. And so we'll go through the checklist from top to bottom, the genetics, the ENT, the eyes, and it's done in sections, and then we'll tick off, have we done this? Have we done that? Have we done an ultrasound of the kidneys? One of the things that gets done quite early on in the neonatal unit, or we might do, is an MRI of the semicircular canals, an MRI of the brain, but particularly cuts of around the inner ear, the semicircular canals. They are classic in charge syndrome. They are classically. So one of the things in charge syndrome, it's the hearing is involved, but it's the balance as well. So again, I would say cranial nerve involvement and sensory involvement. And that's a very interesting syndrome that can present as a child with lots and lots of developmental problems, but it's the cranial nerves and the sensory that have been affected. And they're trying to think of you and me if we didn't have our balance. You're all, especially when you're trying to walk and crawl and sit up, you're all off balance. So you look quite motor delayed, but actually there's nothing to stop you walking. It's just you haven't got it's like you're on a ship all the time. So I think with there's been so much to learn medically with charge. It still really intrigues me. It's still really, I fight for what could be going on here. So it's interesting. So the checklist is really important, and I think we just follow that. It's like a recipe. We follow the checklist, make sure that. One of the other things that's really important, and I've done the research on that quite some while ago, is that it's important when you bring the kids in that they have multiple appointments, probably on the same day, so that they're not having so many visits to the hospital. But more important, if they need procedures like change of a G tube, their ears cleaned out and a tube put in, maybe their nose tube needs altering, they need a stent put in there, maybe they need their teeth cleaning, and then maybe they need something more substantial like a scope, because they're looking for reflux, they're looking for other things. So that's 4 or 5 things that you could easily, not the heart stuff. The heart people like to leave the heart. They like to do their heart stuff, and they like everybody else to do that. But anything that really doesn't involve that you're going to get infection somewhere, it's important to put those together, because anesthesia risks in charge syndrome are huge. So we can talk a little bit more about that. But again, there's a good paper on the website. So trying to organize these in, and I can think of that being very important for lots of different syndromes, but particularly in charge where you've got upper airway secretion problems. So they get a lot of what we call post-anesthesia events, which can be disastrous. They can result in morbidity, mortality. I've been actually an expert witness on a few cases where people have said, well, wouldn't the child have died anyway? And I said, no, this was because they had anesthesia after anesthesia, and it was a little procedure. The anesthesiologist wasn't an expert and couldn't get a tube down, couldn't rescue the airway. So anesthesia risk is important. And again, that's one of the areas of research that I've done a while back.
Yeah, I think knowledge in general is, as you said, like knowing that you have this kid that has like a complex medical thing going on, and really trying to figure out how to do it all together. I think it's also important for the family and the parents, and not just only and for the kid.
Yes.
So it's not just about, life and death for sure. If you're putting someone under anesthesia, you should know the risks and what it involves, but also just how to make the patient care less, scary or intimidating or just hard.
Absolutely. Absolutely, it makes sense, and it's been so hard to do that. But now we've got a paper that shows you need to do it. You can give that to the anesthesiologist and say, we need to do this. It's not, it's convenient for us. This is for the child, as this is for the child's health as well. I agree.
Yeah, so that's a super important. Thank you for letting us all know this. I really hope, guys, that when we get into our clinical learning part, you will remember this. This is important. So now we're going to jump into the part about your research. I have to say that your research is extensive. I feel like it's very rounded around the syndrome. It goes all the way from gut microbiome to migraine treatment. It's everything and anything in between. Guys, again, go to the website. You will be amazed. So what is the goal of your research?
I think when I started this, I was just fascinated with little Nicholas on Great Ormond Street. I was fascinated with this syndrome that seemed to be so inappropriately written up in the, it's a narrow field. And I think if I'm speaking out to all of you, don't be afraid of doing narrow. Some of you are going to be amazingly, researchers with great grants, lots of lab people and work. I'm with a small group, usually a medical student. I work with medical students because they're cheap, so I don't have to pay for them. So I usually work with 2 or 3 medical students, and they publish a paper at the end of their time with me after 2, 3, 4 years, however long they stay with me. And then I've done it on a shoestring, and I get a lot of support from foundation, from the Charge Foundation International has supported me with little bits of money along the way, which I've eked out and worked with. The families are amazing. The families work with you. The families are your lab, essentially. I learned from the conferences. I've been going to the international. I invited myself to the first one. I had to move to Newfoundland, and they were holding a conference, I think, within that year or something. And I thought, I'm researching. I was very young. I'm researching Charge syndrome in England. I think I was 31 or something like that. And I thought, oh my goodness, I want to be. So I invited myself. There was a whole lot of geneticists and me. I was the only clinician. And they said, well, who, and we had a little group of people interested in researching Charge syndrome. They said, well, who wants to take over sort of thinking about writing the new criteria instead of the CHARGE? Who wants to write the new criteria for Charge syndrome? And I put my hand up. I said, I will. I'll write it. I'll do the research. And then I was paired up with one of the great geneticist, one of the ones that was involved in the original diagnosis, and we called it the 4 C's, and we went from there, and that was my original big paper. But the one that I published in England that's actually not even on the website, which I'm going to put on, I think, was about a family support group and how important the families are, because I got involved with the families. So also with all of you, if you're interested in something or anything, think about, especially clinical, getting involved. Now it's very common for people to get involved with families, but it wasn't back there. And I visited the family support group quite a few times when I was in England, and we interviewed, I took pictures. No ethics, by the way. I took pictures. We measured the kids. I did a growth in Charge syndrome, which was an old paper, and we actually took some blood as well. But that was a long while ago. So we did this, but the families were amazing. And I remember some of the families. I actually had, as a little side, I came through Heathrow because I come and see my family a lot in London. And I met one of the families standing there, and I saw the kid and I saw the dad. I thought, oh my goodness, I know who that is. And I wait, who comes through Heathrow and knows somebody with Charge? It's like I see somebody with Charge syndrome all the time, but that's a little side. But my research now is in, I love the vagus nerve. I think the vagus nerve is incredible. It's the wandering nerve, the longest nerve. It's not working in the gut. We've said that with our zebrafish model. we've just published a zebrafish anesthesia model paper, which isn't on the website yet because it's literally just got published. So these are the two zebrafish. Now, I didn't own the lab. It was owned by the zebrafish lab guy, who unfortunately moved. So if anybody's interested out there and they've got a zebrafish lab, I'm still interested, and I've got things we can do with charge syndrome. But I still have my zebrafish who have got charge syndrome here. I can breed them. Well, I don't, somebody else does. So I'm interested in the microbiome and the gut, and I've always been interested in the gut. The gut is very interesting organ for all of us.
Yeah, I completely agree with you. From the little bit I know, and I've been studying about the GI tract, it's amazing.
One of the things we have done, which I'm presenting at the next conference, which will be soon up on the website, is about a vagal nerve implant for kids that have got charge and epilepsy and POTS syndrome. So the other area I'm doing clinically is postural orthostatic tachycardia syndrome, POTS. Do you learn about POTS? Do you knowledge
Not
about
yet.
POTS? Okay, so I would say to all your listeners, that's a global thing. It's part of long COVID now, so it's very, very sort of in, if you like, in things. But we think that these kids have got this as they get older. We've made much more frequent than in the general population. So POTS is related to vagal nerve, is related to all of this. I think it's worth educating yourself about POTS. I didn't know too much about it until about 5 years ago.
Yeah, well, I guess we will. We have a couple of more years to figure it out. So would you say that you're mostly focused your research on children, on adults with charge, prenatal? What would be the more like?
I think I'm moving into the older I've certainly been moving into the older population. I did some research on puberty in charge, knowing that they can have delayed puberty or arrested puberty, which needs to be looked after. Very important to have high doses of vitamin D, weight-bearing exercises for bone health. Bone health was when I got into more the adolescents and adults. Now I think with the gut stuff, it's very important if you've got researchers that can follow a population into adulthood, which I've been able to do just because I've kept in touch with a lot of my patients, or not even my patients, my families that I followed in the international charge syndrome. So I think that's where the POTS comes in. That's where knowing that these kids can get to be adults and they can have volvulus of the gut and things like that. So I think that there is a real problem with pediatricians stopping pediatric research and adults starting the research. That middle bit is, I think, open for grabs for lots of people. And I think following syndromes particularly, or groups of people over time is really important for anything. So I think if if any of you are interested in any area, if you can follow over time, so it's of course more prospective, more follow-up. But even if you do it from a point of view like I've done, I started more with the little ones, and they've grown up. They've actually literally grown up, because a lot of them didn't survive or weren't diagnosed. So I'm definitely veering, but I go back and forth. Migraine was a little girl that I saw with migraine, and the Botox here worked for her migraine up here because of trigeminal nerve. That's a very interesting that's a case report on the website. So I'm hoping I've given you a lot of go to doctor. There'll be a whole spate of people in Israel visiting the website.
I really hope so too. So we're almost out of time because Zoom is giving us a time deadline. I wanted to know if there's anything else you would like our listeners to know, any kind of shout out about research or anything else.
At my older age now, don't ever get put off. I was not put off by my professor, and it was my husband at the time, who's Israeli, who said to me, don't keep going, Kim. You've got a passion, you're interested, and I said at the beginning, I have a bit of dyslexia and ADHD myself, so I struggled a bit with schooling, with so do it, you know, just do it. And I've worked with a lot of great people. I've found that working, even just doing something like this, is wonderful. I like working with other people and getting enthusiasm from them and giving them my enthusiasm. So I'm available, kblake@dowell.ca. I get lots of people reaching out to me for all sorts of things. Yeah, I've had a very, very lovely career. I'm still interested. I'm still researching. I don't know when I'm going to stop, but the families are everything, and my students are everything. I teach a lot still. So yes, that's my life in a nutshell, really.
Thank you again so much. It was a pleasure having you with us. Thank you so much.
Thank you.
Bye.
I've forgotten how to say goodbye in Hebrew. No, that's Boker Tov is good morning. What's goodbye in Hebrew?
להתראות.
Letrot, of course, letrot. Oh, Kimberly. Letrot. Thank
There
you,
we
Yana.
have
Thank
it.
you very much for organizing this. Okay.
Thank you. Bye.
Okay. Bye, letrot.